Assalamu alaikum, dear students. Hope everything is fine with you and your families. We have already finished written almost the major topics, I think. So we will now proceed on to the ocular trauma. So today I am going to discuss mainly the orbital trauma and the eyelid trauma. Ocular or orbital trauma can be subdivided into eyelid trauma, orbital trauma, trauma to the globe, and chemical injuries. First of all, we are going to discuss the eyelid trauma. Eyelid trauma is primarily associated with periocular signs like ecchymosis. There is subcutaneous collection of blood, and there is edema. You can see the swelling here, and there is associated subconjunctival hemorrhage and chemosis. This is chemosis, edematous conjunctiva. But when you see this kind of patients, you need to exclude other possible ocular or orbital injuries. We need to exclude the orbital injuries or globe injuries. We need to exclude the orbital roof injuries, especially if this subconjunctival hemorrhage, we cannot see the posterior extent of this subconjunctival hemorrhage. And we need to rule out the basal skull fracture. Basal skull fracture usually leads to this kind of picture in both eyes, binocular features of periocular ecchymosis and edema. So we need to exclude all these things before labeling the patient that he is safe and he has got just periocular trauma. This trauma, actually, we need to reassure the patients. There is no specific treatment, but we can ask the patient to have the cold fomentation, and because there is no laceration, no need to give any antibiotic, or we can just give the non-steroidal anti-inflammatory medications. So just the cold fomentation and non-steroidal anti-inflammatory drugs. Second is the eyelid lacerations. Here we can see upper lid laceration in this picture. When you see this kind of eyelid laceration, this is usually because of any sharp object. You need to rule out any prolapsed fat, because if the fat is prolapsed, it means the trauma is deep. It is now perforating the orbital septum. So when the septum is prolapsed, septum is teared, the patient needs actually systemic antibiotic, because if this can lead to traumatic orbital cellulitis. So patient needs actually systemic antibiotics. If the septum is prolapsed, septum is teared and there is orbital fat prolapse. And secondly, we need to rule out the levator injuries because if there is injury to the levator levator superioris, the patient is unable to lift the upper eyelid, and we need to repair the levator before closing this wound, this lid laceration. So if there is injury to the levator and patient is unable to lift the upper eyelid, in this case we need to repair the levator prior to the lid wound repair, like in this case. Okay. Here we can see again full thickness lid laceration, which is very close to the canaliculi, and the treatment is approximation of the tarsal plate with absorbable sutures, which is Vicryl. We use Vicryl and we approximate the tarsal plate first, and then we close the wound with silk, 40 or 30 silk. Okay, so But here again, when this kind of injuries, as we can see, this is close to the lacrimal canaliculi, we need to rule out any injury to the canalicus, because that should be a priority to repair, otherwise the patient is going to have epiphora. This is the picture of if the patient is having basal skull fracture, which is usually because of a fall, the patient will present to you with bilateral periocular ecchymosis, like here, and there is subconjunctival hemorrhage, and there is bleeding from the nose, and there is no active treatment except as I told you earlier, the cold fomentation, or if the patient is having any laceration here, then topical antibiotic, or if you think there is a orbital septum, which is not actually a problem in this case, we can give systemic antibiotic. But here in this case only, cold fomentation and reassurance to the patient. The second and the most important topic in the orbit is orbital floor fractures. So what is the mechanism of orbital floor fractures? This is actually caused by trauma by fist or a tennis ball, which is more than 5 centimeter in size. So it compresses the globe, and there is sudden increase in the intra-orbital pressure, leading to the fracture into the orbital floor, because orbital floor consists of the weakest bone. The rest of the bones, especially the lateral orbital wall and the superior orbital wall, they are relatively thick bones, but mostly this causes infraorbital fracture, floor fracture, and it can also lead to the medial orbital wall fracture. But this is the most common which we encounter in our clinical practice. As I told you earlier, it most commonly involves the orbital floor, because this consists of thinnest portion of the thinnest bones. On examination, if you see this patient who comes to you with trauma, history of trauma with fist or with tennis ball, he will have severe periocular ecchymosis, and there will be severe subconjunctival hemorrhage with chemosis. See, this is bulging conjunctiva, and there may be associated ocular damage also, blunt ocular features, eye having features of blunt ocular trauma, which we'll discuss in the next lecture, inshallah ta'ala. And there is usually orbital anesthesia. There is anesthesia here along the infraorbital margins because of damage to the infraorbital nerve, and there is restricted elevations. You can see there is trauma to the right eye or right orbit. We can see this eye is showing full elevation, but this eye is showing restricted elevations, and we can see also in ophthalmos also. If you go behind the patient and ask the patient to look down, we can see the globe here, but here we cannot see. So again, there is right in ophthalmos, and there is restricted elevation in the right eye, and there is diplopia also because of the entrapment of the muscles or the orbital contents, orbital fat into that fracture area, or sometimes there is intraorbital hemorrhage, which can cause tenting of the muscles, or that can cause the restriction of the ocular muscle movements also. That is also a reason the patient can have diplopia. So there are two mechanisms of diplopia. One is the entrapment of the intraocular, extraocular muscles or the orbital fat into that fracture, or there can be intraorbital hemorrhage. How we investigate this or confirm that the patient is having diplopia? So in order to investigate diplopia, we have to do this Hess test. And Hess test actually is important in the assessment initial assessment of the patient and subsequent monitoring after the surgery. See, we can see here this eye, this is the right eye and this is the left eye. We can see the restricted eye movements in elevation, okay, and here there is eyes showing full movements all around. Here we can see the patient is having restricted elevation and restricted depression here, but the rest of the muscles, the medial and the lateral recti are normal. The movements are normal in this direction, but because of the entrapment of the inferior rectus muscle into that orbital fracture, there is restricted depression and restricted elevation. Okay. How do we treat this problem? We actually need to observe the patient. There is no hurry for the surgery, and we observe the patient and give him systemic antibiotic, ice packs and nasal decongestant, and we ask the patient to avoid to blow the nose, because this can lead to the expulsion of the sinus contents into the orbit. If the patient blow, it can lead to the expulsion of the sinus contents into the orbit. And if patient is having orbital hemorrhage and there is significant edema, orbital edema, which is compromising optic nerve function, or there is optic nerve compression, so we need to prescribe systemic steroid also in these patients. Subsequent treatment, which is usually done, is surgical, and this is to prevent vertical diplopia and cosmetically unacceptable anaphthalomas. Treatment is mainly surgical, and we need to do the surgery after 2 weeks when all the edema is settled and the patient is still having vertical diplopia, or the patient is having anaphthalomas. In some cases we need to do urgent repair, surgical repair, like in cases which the patient eye is white and white, there is no ecchymosis, no conjunctival congestion, but the patient is having oculocardiac reflex. It means there is entrapment of the ocular contents into the orbital contents into that orbital fracture, and patient is having oculocardiac reflex or bradycardia. So in these cases we need to do urgent surgery, or if the patient is having severe anaphthalomas. So this is the today's lecture about the orbital trauma and about the lid trauma. Thank you so much.